Hi, everyone. Good evening. Thank you for joining me. Um, we're going to talk this evening a little bit about the basics of fertility, kind of fertility 101, if you will, and essentially everything you wish you had learned in health class, or maybe you did and you forgot. So in terms of um, your host, myself, Ilana Ressler. I'm a reproductive endocrinologist, which means that we train as OBGYNs for 4 years in residency, and then we do another 3 years in fellowship training to subspecialize in the field of reproductive endocrinology and infertility. I am part of Loom Fertility. We are a practice based out of Connecticut, also with a Westchester office. We have 5 locations. We have 9 board-certified reproductive endocrinologists in our group, and we have on-site surgical suite as well as the IVF laboratory, and we also have andrology labs in all of our different locations. We pride ourselves in many ways, including a program that we have, the Integrated Fertility and Wellness Program, which I'll tell you a little bit about this evening as well. And essentially, we offer a full range of fertility services, and I will explain a little bit more about that as well. So, in terms of what we offer, we evaluate fertility for those who have maybe been trying, or even for those who haven't tried yet and are just curious about a reproductive checkup. We offer fertility preservation by freezing eggs, sperm, or embryos, and we offer all the variety of fertility treatments, including IUI and IVF type of treatments. We also offer donor egg, donor sperm, and gestational carrier treatments. We also believe in treating the whole picture. We have this integrated fertility wellness program with acupuncture, counseling, dietitians, and different support groups. So let's get started discussing a little bit about fertility. So first of all, what is infertility? So the traditional definition of it is when a couple has been trying for a year without success. If a woman is 35 or older, we say after 6 months of trying to come in for an evaluation. This definition was recently expanded and changed last year by the American Society for Reproductive Medicine to needing medical intervention in order to achieve a successful pregnancy, either as an individual or with a partner, which is a more inclusive definition of infertility. So we know that there are some basic building blocks that are needed in order to conceive. We need an egg, we need a sperm, and we need a uterus. And of course, there are all sorts of ways to put these parts together in terms of building a family. But I want to start a little bit by talking about female anatomy and what happens in like a regular menstrual cycle, because really understanding this is kind of the basis for all of the testing and treatments that we do. So in terms of just review of basic female anatomy, vagina is here, cervix, that's like where a pap smear is taken. That's the entry into the uterus. These are the fallopian tubes and the ovaries. So inside of the ovaries is where the eggs are stored. We can't see the eggs, they're microscopic, so too little to be seen, but that is where they are stored. And every month there's like a group of these eggs available for use. Those eggs are contained within little structures called follicles, and we can see follicles on ultrasound. So I always like to think of the ovary kind of looking like on ultrasound, like a chocolate chip cookie, and all of the little chips inside, each one of those is a follicle, and inside each follicle is an egg. In terms of what happens during a normal cycle, so don't worry about all the details here, but this is just to illustrate what happens in a normal 28-day cycle. So from the start of one period to the start of the next, that's the average length. But anywhere between 21 and 35 days is considered a normal range. So this is what's happening in the ovaries. This is what's happening in the uterus, and these represent different hormones. So at the start of every cycle, or when a period begins, there's like a whole group of these follicles waiting, ready for use. And then there's hormonal signaling that happens between 2 places in our brain, down to the ovary, it feeds back, and that's what carefully regulates the cycle. So in particular, there's this hormone called FSH, follicle stimulating hormone, made by the brain that sends the signal down to the follicles. And one of these follicles is selected to become what's called the dominant follicle. So it takes about 2 weeks for that follicle to grow and that egg to mature. That growing follicle is making estrogen. That estrogen is building the lining of the uterus. Mid-cycle, another hormone signal comes from the brain called the LH surge, and that tells the follicle, okay, time to ovulate and release your egg. So actually, I'm going to go back a second. So once that happens, that egg leaves the ovary, it's swept into the tube. It's there for about 24 hours or so. That's when it can fertilize, but sperm lives longer in the reproductive tract. So with intercourse, sperm would be left here. Some of it would make its way up through the uterus to the tube. This is where the egg and the sperm would meet. Once they meet and fertilize, it becomes an embryo, and then it takes about 5 days to travel into the uterus where it would implant and grow. So after ovulation, this site in the ovary then becomes what's called the corpus luteum, like where ovulation took place. That is then making progesterone. If no pregnancy occurs, the hormone levels fall, bleeding begins, and this whole cycle starts again. So I think it's really important just to understand these basics, because everything we do in terms of like evaluation and treatments is like kind of comes from this and is the manipulation of what happens naturally. So I'm going to talk a little bit about each of these different components. In terms of eggs, we consider both quantity and quality. And quality is really the most important, and that is closely associated with age. So there is no like way of doing a test on egg quality. We just know it's closely associated with age. It is at its finest before the age of 35. In our mid 30s, that starts to slowly change. Once we are 40, most eggs are no longer healthy. And once we're in our mid to upper 40s, really very few to no healthy eggs left. So we can test quality if doing IVF. We can like take a little sample of an embryo and test it chromosomally or genetically to see if it has the proper number of chromosomes. But otherwise, there isn't really a quality check. But in terms of quantity, there are 3 different measures that we use to evaluate the quantity of eggs. So there's a hormone called anti-Mullerian hormone, or AMH. This is a hormone made by cells that surround the eggs. So the more eggs someone has, the higher her AMH, and that goes down as we get older. The second marker is the day 3 FSH. This is that hormone I was talking about a slide or two ago that gets the follicle to grow each month. It should be low at the start of the cycle, so we draw it then. As ovarian reserve goes down, the FSH will increase. It's the inverse relationship. And then we do a basic transvaginal ultrasound. We look at the ovaries, we count the little follicles or those chips in the cookie, and that is the third measure. So really what this is telling me, I put the information from those 3 markers together and I get a sense if someone has like a low, average, or high reserve. We cannot count how many eggs are left or know when they'll run out, but it really helps us know like how aggressive to be, how to dose medications, expectations of how someone might respond, but it is not predictive of the ability to conceive. All right, so at a certain point, though, whether it's due to quantity or quality, our eggs are no longer viable. And that happens to everyone at a certain point, typically like mid 40s, for some earlier. So for those, if they are unable to use their own eggs, we do offer donor egg IVF, which is a highly successful type of treatment. And we have a whole program dedicated to doing that. So we are born with all the eggs we're ever going to have. We actually had about 6 or 7 million before we're born. By the time we're born, about 2 million, about 500,000 by the time we go through puberty, and they're like rapidly lost throughout our life. And at menopause, they're all gone. So that average age in the US is 51. But again, well before this, starting in our mid 30s, that's when we start to notice these changes occur in terms of egg quantity and quality. So again, age is one of the most important factors, or like one of the biggest predictors of success with fertility treatment. And again, starts to change in our mid 30s, but it can happen even sooner. So it's always, possible to just at any point have those ovarian reserve markers checked just to get a hint into whether it's normal as expected, or maybe it is a little lower than expected, which might, prompt further steps to be taken sooner. So I want to talk a little bit about the other parts of the fertility evaluation. We do a test typically called a hysterosalpingogram, or HSG. This is to evaluate the fallopian tubes. So remember, the tubes are the meeting place for the egg and the sperm. We want to make sure they're both open and healthy. So we do this by placing a small catheter in the uterus and putting a little dye in there that we can see with an X-ray. And we take pictures as the dye is filling into the uterus, and we see it filling into the tubes and spilling out of both ends. This is a normal HSG showing both tubes are open. If one is blocked, we can still proceed with different treatment options. If both are blocked, then that would require IVF, because the egg and the sperm have no way of meeting in the fallopian tubes if both are blocked. We also do a more detailed assessment of the inside of the uterus, what we call the uterine cavity. This HSG gives us a little bit of information. We can see in this one, for example, it's a normal shape. So some people are born with a different shape of the uterus, and we would be able to see that, for example, on an HSG. But we want a detailed look. This is a very obvious polyp sitting in the middle of the uterine cavity here, but often they're smaller, more subtle. But this type of exam would let us pick that up. So we put, again, a little catheter into the uterus. We put a little saline in there because the walls of the uterus are typically touching. So on a routine ultrasound, we can't see what's in there. So by infusing a little bit of saline, it just gently pushes apart the walls. We do an ultrasound with 3D imaging. This is a 3D rendering, an example. And again, sitting right here in the middle of the cavity is a huge polyp. So as you can imagine, this would definitely get in the way of an embryo implanting. So if we found something like this, or even more smaller polyps, or sometimes we find scar tissue or little fibroids, we would want to take them out. And we do that procedure in our office. We have, again, an ambulatory surgery center within our office, and we do these surgeries very routinely every day. Okay, so of course, the other half of the equation is the sperm. A semen analysis is the test that we do to assess the health of the sperm. We check really three main parameters that we're interested in. One is the concentration. How many million sperm are there per milliliter? The motility is the second factor. What percentage of those sperm are moving well? And the third parameter is the morphology. How many are normal in shape? So this just gives an example of a normal looking sperm. And here there are different examples of abnormal looking sperm. So it's interesting, most sperm are abnormally shaped. Okay, so in terms of a normal semen analysis, we would like to see greater than 4% normal forms. So that means most sperm are abnormal. It is thought that abnormal sperm cannot fertilize eggs. So again, we're looking for a certain percentage, granted it's a fairly low percentage, to be normal forms in order to have a normal analysis. And then if it's abnormal, let's say we find an abnormality with the semen analysis, we typically repeat it, because the life cycle of sperm is close to about 3 months. It's continuously turning over, and we don't know, was that a good day, a bad day? We want a little bit more of a sense of an average, so we would repeat it. And if there are persistent abnormalities, that would prompt further evaluation that's typically led by a reproductive urologist, who we would refer you to. Okay, so I've covered really the different kind of building blocks or ways in which we assess fertility. We can have various findings, of course, and we might find only one, we might find more than one. So we really like to do this comprehensive evaluation at the start, because we don't want to focus in on one thing that might be obvious and miss another thing that would be discovered later on. So we really like to do the comprehensive evaluation. We could find that there's an issue with the sperm, which would be male factor. We could find something with the tubes, with the uterus. So about a third of the time we find something related to the female, about a third of the time to the male. The other third, it could be a combination. or about 20% of the time we find nothing abnormal on the test. It doesn't mean that there's not a problem. It just is what we call unexplained infertility. So the way I think of it is reproduction is really complex. This is a really complex process. We have like limited ways of kind of getting a glimpse into these different components. But there certainly can be other things going on that we can't actually see. But nonetheless, we have specific treatment even for those with unexplained infertility. There are also those who might not have a reason such as those listed above, but may need help building a family, for example, with use of donor sperm or donor egg or gestational carrier. So, of course, there are many different reasons to be going through the various treatments. So what are the treatment options? There is something called ovulation induction, which is like a gentle stimulation of the ovaries. So I mentioned how one egg typically develops in a cycle. That with ovulation induction, we might get like 2 or 3 eggs to develop. This is particularly useful for those who don't have regular cycles. So for example, women with PCOS might have very irregular, unpredictable cycles. And with use of this type of treatment, we'll just kind of get the follicle to grow and we track it so it's more predictable when she would be ovulating. We often combine that with IUI, intrauterine insemination. There's in vitro fertilization, which is a more aggressive stimulation of the ovaries to try to get many eggs to develop. And then we take them out of the body, combine them with the sperm in the lab to create embryos and transfer an embryo into the uterus. There's fertility preservation, in which we would freeze eggs or sperm for future use. There is donor conception, as mentioned before, use of donor egg, donor sperm. And then there are those who might not be able to carry a pregnancy and need the assistance of a gestational carrier. So I'm going to kind of touch briefly on these different treatments. So in terms of egg freezing and IVF are essentially the same. The difference is just once the eggs come out, what happens. So we do use hormones, the same hormones as I was mentioning earlier. That FSH hormone is the main one to get the follicles to grow. A woman takes those medications for about 10 days or so by subcutaneous injection. So little needle just under the skin in the abdomen. We're monitoring and watching those follicles grow until we feel they're ready to come out. And then she would be set up to have an egg retrieval. This is a procedure, very minimally invasive. The patient is asleep and comfortable, does not feel anything during this procedure, but we place a needle through the vaginal wall into the ovary to basically drain the fluid from each of the developing follicles. And along with that fluid should come an egg. And then the eggs that same day would be frozen. We use a method called vitrification, which is very effective at freezing eggs. There was this old technology called slow freezing that was very good for freezing sperm and embryos, but not so good for freezing eggs. But then vitrification came about, which is very good at freezing eggs. And so about a decade ago or so, the experimental label on egg freezing was lifted because when we thaw eggs now, with the old technology, many didn't survive the thaw, but now we expect like more than 95% to survive a thaw. They're stored essentially indefinitely until someone is ready to use them. Then they would need to be thawed, put together with the sperm at that point to then go through the process of creating embryos, which then can be transferred into the uterus and also can be frozen again for later use as well. So intrauterine insemination, this is, as I mentioned, often combined with the ovulation induction. So first we, again, track the development of the follicles. We help time ovulation. And so at the time that is when the eggs would be available, we would then place the sperm in the uterus, essentially closer to the eggs at the right time. So just some little facts about this. It is would be considered like less invasive than IVF. It's typically would be lower cost in terms of the processing of the sperm. So it's washed, it's concentrated, it's placed in a little syringe attached to a catheter. And again, we place the catheter in the uterus, leave the sample there. We have a woman rest for about 5 minutes afterwards, then she can get up and continue her normal activities. So it really doesn't change or interfere much with day-to-day activities. This would be suitable if there's like a very like mild male factor or problem with the sperm. And this is actually the first line treatment, as I mentioned, for those with unexplained infertility. The first line treatment would be ovulation induction with IUI. Okay, in vitro fertilization. So essentially, I just reviewed the egg freezing process. It's the same thing, but once the eggs come out, right away they would be combined with the sperm in the lab. We would then grow the embryos into a certain stage called a blastocyst, and at that point, the blastocyst can be transferred or again frozen. So this involves, again, taking the hormone injections for about 10 days or so as we watch the follicles develop, then taking the eggs out of the body and going through the embryo development process. This is our most successful treatment. So in IUI, ovulation induction IUI, in sort of a perfect gold standard scenario where a woman's under 35, good uterus, good tubes, good sperm, works up to about 20% per cycle. So it does often take more than one try to be successful. There's cumulative success. The more you try, the more likely you are to succeed. Studies showed that peaks around the 3 cycle point, and there's like diminishing returns after that. So if someone isn't successful after 3 IUI cycles, we would typically recommend moving to IVF, or many go to IVF directly because it's going to offer up to 60 to 70% chance of success per transfer. So it's going to be higher likelihood of success. It also, provides the ability to put away and freeze embryos for future family building. So I think it's always important to think about not only if someone's trying to conceive, not only trying to conceive now, but what does that future family building look like? And perhaps it makes sense to make embryos and freeze them for future use to make it easier in the future to do so. Okay, and in terms of donor conception and surrogacy, there are various reasons why someone might use donor sperm or donor eggs. For example, same-sex female couple would need donor sperm. A same-sex male couple would need donor egg as well as a gestational carrier. We have single women who are building their families who use donor sperm to do so. So there are, again, many different situations. Another example for use of a gestational carrier would be there are some women who are actually born without a uterus. They have ovaries, so we can create embryos from their eggs, but then they need someone else's help to carry the pregnancy. So all different, reasons and paths to parenthood that we can take. Okay, so lastly, I just want to talk about, kind of the bigger wellness picture. I think this is important. We always want to look at the whole person. It's not just focus in on what, fertility treatment can we provide, but we want to really think about, mental health, other physical health, and so on. So, of course, the holidays are coming up. It's important to, give yourself some self-care, and holidays can be stressful, especially if you are trying to conceive and other family members are around and maybe inquiring about it or just feeling additional stress. So just some few tips. These actually some of them from our dietitians. We have 2, as I may have mentioned, 2 dietitians in our practice that work with many of our patients. They're really wonderful resources, but we want to stay hydrated, bring a water bottle to events, basically listen to your body with the eating. It's easy to overeat, especially with our upcoming holiday next week. Try to continue to involve movement, even, a brisk walk. I generally recommend following American Heart Association goal for exercise, like 30 to 60 minutes, 5 days a week of some sort of movement. Take some time for yourself if you need some quiet, okay, to step aside. Okay, so at this point, I would, just like to mention in terms of next steps, we are here happy to meet with you individually and review your personal history and talk about what next steps we can do to help you. At this point, though, I am happy to open it up for questions. So there should be, I think, a place where you can place the questions. If you have any, please go ahead. And while you're doing that, I just wanted to point out on this screen here are our various locations. So our main headquarters IVF lab is in Norwalk. Our satellites are in Danbury, Trumbull, Stamford, and Harrison, New York. All right. Any questions this evening? Okay. All right. So there's a question about how does a trigger shot work? So in terms of, so what is that mean, a trigger shot? So when we are doing a treatment like ovulation induction, as I mentioned, we are doing a gentle stimulation of the ovaries, like giving a medication like Clomid or Letrozole to kind of typically to boost, excuse me, their growth. And then mid-cycle, at some point, ovulation would occur, right? But we want to control that timing and know when it happens. So the trigger shot does that for us. It will essentially like induce the LH surge so we know how to time things precisely. So the ovulation predictor kits are really, when in treatment, are not needed because we are tracking, like when you're coming in for ultrasounds and blood work, we're actually tracking the LH levels through blood work, which is a much more accurate method of doing it. We're also tracking progesterone. So if we see progesterone levels rising, if we see the LH up and the progesterone up, we know that ovulation is taking place or maybe already took place. So I don't encourage the use of ovulation predictor kits, especially when in treatment, because it can get confusing. And when we're monitoring everything in the trigger shot, we'll time and control when the ovulation occurs. By the way, just as an aside about the ovulation predictor kits, I will say that if someone has regular cycles, like every 28 days, we know that that woman is ovulating and she's ovulating around day 14. Okay, the first part of the cycle can vary in length of the follicles growing. So if it's like a 30-day cycle, then ovulation is occurring more at day 16. It's typically 14 days from ovulation to the time of a period. So if you time intercourse every other day mid-cycle, you will cover that time frame, such as days like 10, 12, 14, 16, something like that. So I think the ovulation predictor kits for some can be helpful. For others, I think it can be actually like very tedious and stressful, especially for those with PCOS. They are not going to be accurate. I really discourage their use in that situation. Okay, another question. How long after trying and no success should I start looking into other resources? So I would say, it can take up to 12 months. If a woman is 35 or older, we say don't wait the full 12 months, wait only 6 months of trying. I think, look, there's, in my opinion, little harm to gathering information and just doing what we would call like a reproductive checkup. I have people that come to me who have not even started to try, but just want this information to help maybe guide them. And if we find out, for example, that someone has like lower ovarian reserve than expected, maybe that would prompt even doing like a fertility preservation type of treatment, freezing eggs or embryos to take some of that stress off of timeline. But I'd say it's totally normal to take several months. So I would say not necessary before 6 months of trying, but better to come sooner rather than later. What we really don't like to see is when people have been trying for years and years and years and then, come in and there may be regret over not doing things sooner. Okay, perfect. So I think that's all the questions for the evening. I just want to thank everyone for joining, wishing you happy holiday season and hoping everyone stays well. Take care. Bye-bye.